Good evening. My name is Bob Resnik from Cary Adult Medicine, up the road from most all of you. I appreciate you all taking some time out of your busy day to discuss a very important topic as it relates to our Medicare Savings Accountable Care Organization venture with Wake Med. This is a very complex subject and one that requires some effort to fully understand. Tonight I'm going to summarize the most important points about the Medicare Risk Adjustment Program and try and provide you some steps that your clinic that you can take to help ensure that you can be successful in the shared savings program for providing quality and cost-effective care. It is imperative, though, that all providers in our network understand this model, or as a group, we will not be successful. I want to stress from the onset that this is more to understand about the Medicare Risk Adjustment Model. You have to follow all guidelines for coding in the ICD-9 2000 coding book, and you must use the appropriate documentation. Many of us are creatures of habit, and we use so many diagnoses that sometimes we tend to remember the more frequent ones, and sometimes those are the less specific ones, although our patients may be more complex. Some examples of that are using 401.1 or 9 for hypertension, the uncomplicated diabetes 250.00, depression is 311, coronary disease 414.01. Now, usually these codes can support our level of E&M coding for our office visit, but for a Medicare risk assessment program, they sometimes aren't the most specific codes to give us the best idea of what our actual expenditures should be projected by Medicare for our patients. Medicare takes all these ICD-9 codes and comes up with a formula to assign expenditures based on those codes. The 401, 401.9, 311, 414, they get an additional $0 assigned to them. The higher specificity codes, they better define the financial risk, like the 402.10, which is hypertensive heart disease, or the 250.40, which is renal manifestations of diabetes, which are more specific, demonstrating the manifestations of the disease. Those do risk adjust, and those do have a financial expenditure allotted to them. So, to be successful in Medicare shared savings, you have to focus on risk coding to get the proper estimated expenditure per patient. If you do not code correctly, you will have little chance in the shared savings despite providing the most cost-effective, high-quality care. What is the Medicare Risk Adjustment Model? Well, the Centers for Medicare and Medicaid devised this as a payment system for Medicare Advantage programs. The goal was to pay these plans for the enrollees based on demographics and health status. They called this the hierarchical condition category, or as we'll refer to it, HCC payment model. The same system is now used for Medicare shared savings, and it relies on the codes that we as primary care providers submit. Now, the risk adjustment codes fall into several categories, and what CMS has done is they've taken each code and it falls into one of these 189 defined CMS HCC condition categories. CMS only uses 70 of these categories, though, in their risk model. So some conditions are going to have no effect on the beneficiary's risk scores. Some conditions, such as diabetes, cancer, are actually represented by multiple HCCs, and they're going to differ because of severity. In 2014, the Medicare risk adjustment model will move to 79 of these hierarchical condition categories. So what are the HCCs? Well, basically you start with the 13,000 ICD-9 codes. You then break them down into these 804 diagnostic groups, and then CMS has taken that and broken that down into 189 condition codes. They then apply the hierarchies based on acuity, and they come up with this hierarchical condition category ranking, and they only use 70 of those. So we take an example here of a diagnosis, anterior MI 410.91. It goes into the diagnostic category of 81.01, which is an anterior MI. It goes into the condition category, which is also the MI category, and then the HCC category, which is 81 AMI. And they do the same here with emphysema, renal disease, but you will see acute problems are not risk adjusted because they are just that, acute. They risk adjust the chronic problems. So an ankle sprain or chest pain, those will not risk adjust. This is a kind of representation of the top 50 HCC codes. As you see, HIV, AIDS. You can see diabetes here has actually 5 categories, starting at 15 with renal and peripheral circular manifestations, going all the way up to 19, which is our 250.00, or our uncomplicated. And you can see they apply these values, which are actually multipliers for the amount of money that they're going to assess to our particular patient population. So CMS determines that the beneficiary cannot have more than one of these HCC diagnoses in a condition group. So for example, diabetes has those 5 HCC categories, 15 through 19. It will take the highest one, which would be, if it was a 15 like renal, it would trump the 19 of the uncomplicated. And then it assigns the cost based on that. And here's an example of that. Say a patient has end-stage liver disease, the hierarchical category 25 would apply, so cirrhosis and the other categories in 27 would not apply. In diabetes, 15 would trump your 16, 17, and 18. They also assign risk for certain diseases that tend to interact. So not only do you get a risk score for having diabetes, a risk score for having congestive heart failure, they give you an additional risk score if you have both of these. So diabetes, cerebral vascular disease, CHF, COPD. If you have all 3 of these, COPD, coronary disease, cerebral vascular disease, you get 0.173, and then renal failure, CHF, diabetes, you get an additional 0.477. In 2014, these are going to change a little bit. That's why I put those in red, and we'll talk about that at the end. It's a lot of information. There's a lot of stuff you need to know, and there's a lot of reference materials that you need to refer back to because it takes some time to understand it. We've put it all out there at keymh.com, keymedicalhome.com. You'll see a link to these resources for CMS HCC risk, and we'll have all the different coding tips, all the different slides, everything out there for you to use. This is one of the more important files that I think is very useful. It's the ICD-9 coding file. As you notice, all the diagnoses are color-coded. White means it gets 0 risk adjustment, so there's no dollars assigned. Green and blue, there are dollars assigned. The green is category D, which is Medicare with some pharmacy benefits. They assign some additional pharmacy monies to these categories because they feel the patients are going to need that additional funding. And then the blues are Medicare Part C. So just some examples of that. Anemia does not risk adjust, but sickle cell does. Arthritis, nonspecific, does not. Arthritis inflammatory does. Alcohol abuse does not. Alcohol dependence does. Arrhythmia does not. Atrial fib does. Depression, 311 nonspecific doesn't. Major depression does. Acute hepatitis, no, but chronic hepatitis, yes. Another form out there is the ICD-9 risk weight. So if you actually want to know the weights for each of these disease states, that's out there. And then again, remember, this is a multiplier, which we'll get into in a couple minutes and show you how that works. Typical example, every patient gets demographics. You don't have to code this, their sex and their age. And you get an allotment for that, in this case, $3,400. This patient had an anterior MI, which trumps angina. It's a higher, the 81 is higher than the 83, so they get the acute myocardial infarction code at 2681. They also get COPD at 2975, renal failure, but they do not get anything for chest pain or ankle sprain. So their relative risk factor is 1.583. Medicare allocates $11,800 annually to that patient. This is the example that you have to understand, and this is the whole point for this talk, because we'll go through this and you'll realize how this is determined. But say you have a 76-year-old female. Now, Medicaid or disabled, they actually get a little bit extra because they find that they use more resources, so they get an additional risk factor. This 76-year-old, though, has diabetes, but it wasn't coded. The vascular disease wasn't coded, nor was the CHF. They're going to get a risk score of 0.6 and an annual payment of $5,800. Now, if you do code it, but you don't code it very specific, diabetes without complications, you get the 0.181. Vascular disease, no complications, you get the 0.3. If you forget the CHF, then you not only don't get the CHF, but you don't get the disease interaction between the diabetes and CHF. So you get a risk factor of 1.15, and you're getting $10,000 assigned to that patient for the year. But if you truly code this right with the diabetes with vascular complications, the 250.70, the CHF, the vascular disease with complications, and you get that disease interaction, you've now got your risk score up to almost 2.5. that same patient gets $22,473 allocated as opposed to the $5,800, almost $17,000. So you can see if you don't do this for several patients out, it's going to be very difficult to show cost savings. Key factors here. This model does not carry a member's chronic conditions into the next year. All conditions must be redocumented every calendar year during a face-to-face visit. You just can't code it. You have to do it during face-to-face. This includes everything that's chronic. Diabetes with neuropathy, amputations. According to Medicare, January 1, that amputation no longer exists unless you code it. CHF, MS, AFib, Parkinson's, all of these. This is a good example of why this is a big issue. Physicians in one of these Medicare Advantage programs, in the first year, if we use 100% of these different conditions they coded, you can see what happens in year 2 and year 3. They did not code those because they're not being treated. Well, they're being treated, but they're not being coded. They're coding other things. Because of that, these risk scores are not averaging out to where the patient's acuity should be, and subsequently the expenditures assigned to those patients are well diminished. Now, your CMS 1500 form only allows 4 diagnoses, but you can file a subsequent claim on the same date of service with procedure codes with additional charges. Refill appointments are a good time sometimes to go along and document these chronic conditions, and you can review some of the old labs that were just done, tests or consults. But remember, you have to code the ICD-9 to the highest level of specificity. For those of you that just want to run some sample patients through, you can go out to the scanhealthplan.com, type in the different issues the patient has, and it will calculate the risk score for you. So, what are our important points to remember here? Health status is calculated by CMS each calendar year. All diagnosis is vanished at midnight on December 31st, so chronic conditions must be reevaluated, documented, and billed. Your patient has to see you during that year or they won't have any diagnoses, so be sure to report your claims within 30 days. How does this relate to the ACOs? Well, what they're going to do is take all the patients that are assigned to our ACO, 30,000 patients, they're going to figure out their per capita expenditures. They're going to take those expenditures and apply a growth rate to that so they can trend this, and then they adjust it based on a historical benchmark. And then they give us a amount of money based on our acuity of the patient population that we should be spent on the population that we are treating. They do segregate this into patients that have end-stage renal disease. They're in a special category, or patients that are disabled. Again, they get a bonus type risk score because they tend to use a little more resources, as do the Medicare and Medicaid patients. But most of our aged non-dual eligible patients don't. Also important to understand what newly assigned beneficiaries are. You're going to get people that will move into the city or move out from out of state into our practices. They count what has been coded by their primary providers in the past 3 years. So you have to make sure you go through their medical records and recode all those chronic conditions and get them as part of your problem list. Now, a patient that's a new beneficiary that just aged into Medicare starts with a blank slate. Medicare does not use what Blue Cross or United or any of the other diagnoses were coded. It starts blank with only their sex, their age, and again, if they're Medicare or Medicaid eligible, or they're disabled, or they have renal disease. So why do these risk scores change? Well, beneficiaries get more illnesses. With chronic diseases, sometimes they're cured. The model changes like it is this year. There's demographic factors that change. Beneficiary gets older, or the beneficiary changes into one of those end-stage renal groups or gets eligible for Medicaid. Just a quick example on how these risk scores change. This is Mrs. Jones, 68-year-old female, gets her demographic score, her diabetes and COPD, then it's normalized against the nation to a 0.961. 2013, Medicare adjusts these demographics. As you see, it goes down a little bit, but the disease actually goes up, but they forget to code the COPD. This year, she only gets a 0.632 risk score. In 2014, she goes to 70 years old. That actually triggers a little bit higher demographic score. They've got the diabetes in there, the COPD in there. Now our risk score is 1.035. So in 3 years, we started with 0.961, ended at 1.035, but we forgot the COPD diagnosis in 2013, so it cost us 0.3 risk score. So what does that 0.3 mean? Well, a 1.0 risk score is an average expenditure of about $7,500. Higher risk scores mean that the patient is going to spend more than $7,500 in the year, and lower means they're going to spend less. Just a typical example, male, I just put some numbers in here. These are not exact numbers, but as you can see, this beneficiary's predicted expenditures are $13,000, where our average expenditures are $7,500. That would give him a risk score of 1.73. Risk scores are adjusted to try and keep the average around 1. And as you can see, this is the June 2010 distribution, pretty close to 1 with a standard deviation. So, again, with coding, you have to do this on a face-to-face encounter. It has to be documented. You have to code to the guidelines, and you have to do it during the dates of service within the data collection period. They want an evaluation of each diagnosis on a progress note, not just listing chronic conditions. So you want to say diabetes with neuropathy, stable, meds adjusted, COPD, test ordered, refer to pulmonary, hypertension, uncontrolled, add medicines. CMS considers diagnosis listed on a progress note without an evaluation or an assessment as a problem list. This doesn't count for encounter data submission. Each progress note has to be able to stand alone, and you don't refer to your diagnosis from a previous progress note. So you want to make sure to document all these conditions at least annually. Probable, suspected, questionable, rule out, you can't report those to CMS as valid diagnosis. You have to document how that condition was monitored, evaluated, addressed, or treated. And you want to use descriptors when appropriate to increase your specificity. One thing that a lot of people forget is the permanent diagnosis. They have to be documented as often as they are assessed or treated or when they are in consider of a patient's care. A patient with HIV or amputations or dialysis, quadriplegia, ostomy, all those things play a factor when we prescribe medicines and we see that patient in the office. So even though you're not treating for it, you can code for it, and the patient will get risk assessed on that. Another example is dependence versus abuse. CMS does not recognize abuse as risk adjusted, but they do recognize dependence. You have to make sure you document that. The word chronic changes a lot of this. Chronic hepatitis is risk assessed, where hepatitis is not. When you're showing a clear relationship between condition and manifestation, you have to use the right linkage verbiage. Due to, because of, related to. The word with does not establish that cause and effect, except maybe with diabetes with neuropathy. So use the ICD-9 guidelines. The term history of means a patient no longer has the condition. You want to avoid using history of to document a current condition. Some examples of what providers do is history of CHF to indicate compensated CHF. You want to document it as compensated CHF. History of AFib to indicate AFib controlled by meds. No, you want to document AFib controlled by meds. So if your patient is currently treated for a stable condition, you don't want to use history of because you won't get it risk assessed. So use CHF compensated, COPD compensated, AFib on Coumadin. The exception of this is history of old MI, which is a risk assessed diagnosis 412, and you can say history of old MI. The next stage we'd like to talk about are the specific disease states, just to give you some examples of the key ones that you should focus on in your practice. Diabetes is the biggest. The model has 5 diabetes HCC categories, and as you saw in the first couple slides, there's different levels based on the manifestation. So a patient code that fits into diabetes with acute complications and also gets coded diabetes without complications, CMS takes the higher one. They drop the one without complications. So once they get the complication, they drop the lower one. Key thing in diabetes, many of us just get lazy and put 250.00. Do not use that 4th digit as 0 if there are other related manifestations of diabetes. Use the 1 through 8 codes. Ketoacidosis 1, hyperosmolarity 2, coma 3, renal manifestations 4, ophthalmologic 5, and so on. 6 for neurologic, 7 peripheral, 8 for non-specified. If these conditions are a manifestation of diabetes, you want to use the more specific code. So when you code this, a patient with nephropathy in diabetes, you would code the renal 250.40 first, followed by the manifestation, neuropathy or nephropathy in diabetes, 583.81. Same thing with an eye manifestation. You would do 250.50, and then you document the manifestation, the diabetic retinopathy or the cataract. And here's some more examples of what you would do with PVD or peripheral neuropathy. And again, just a basic, some more suggestions on what you can do under each one of these categories: renal, ophthalmologic, neurologic, peripheral vascular, and other non-specified. Code the diabetic code first, followed by the manifestation. Now, when you document the manifestation, you can document it without listing the higher level of manifestation category. So instead of writing diabetes with renal manifestations, which doesn't specify the manifestations, you want to use chronic kidney disease as a result of diabetes to be more accurate. So how does this translate into our risk scores? Well, let's take a look at some examples here. For diabetes controlled with retinopathy, if you code 250.00 and 362.10, you're going to get a risk score of 0.127 because retinopathy gets no risk score, and the controlled diabetes gets a very low risk score. However, if you use the appropriate codes from documentation here that your proliferative retinopathy is due to from your diabetes, then you use 250.50 and your 362.02. Now you get a risk score of 0.607 just by using the proper diagnostic codes. That's a difference of about $4,000 for that patient. Some other examples with peripheral vascular disease, again, by using the more specific diabetes code, you see a general increase of about a 0.2 or 0.3 on that risk score. Again, that's $1,500, $2,000, depending on how you code that. You want to document all of these. Just because you've documented one manifestation doesn't mean you don't document them all, and there's a good reason for that. CMS is going to take the highest level. In this case, it would be the risk score for 250.72. But all three of these, neuro, other uncontrolled, and PVD, all have the same 0.371 assigned, but they're just going to use that code as the code, and all the other two will be dropped. But now, because you've coded each one of these with their manifestation, they're going to add each one of the manifestations in too. So you're going to get the diabetes, you're going to get the manifestation of the peripheral neuropathy, the foot ulcer, and the peripheral vascular disease, 443.81. And as you can see, your risk factor now goes up to 1.644. Some examples of how would you code for the fourth digit of the diabetes. Again, remember, it's a clinical determination. You have to document it, and you have to have reason. 64-year-old with uncontrolled diabetes, numbness and pain in the right foot, third and fourth toes, has been diagnosed with a Morton's neuroma in the same area by a podiatrist, but never had surgery. So if you feel you can document the diabetes caused this numbness and tingling as a neuropathy, you got to document that. But in this case, with some sort of underlying pathology and it being very localized, you're probably better to use the uncomplicated diabetic code unless they have some other complication. A 54-year-old with multiple cataracts, poor diabetes control. Well, a 54-year-old with cataracts and diabetes, more than likely you can code that as a result of diabetes, and you could use the 250.50 code and then the diabetic cataract code. 71-year-old develops abnormal albumin to creatinine ratio, has a fairly normal GFR. Any abnormality that's secondary to diabetes, proteinuria, microalbuminuria, does qualify as a chronic kidney disease diagnosis, 585. So even though that patient has an 85 GFR, they do have some kidney damage, which is the abnormality in the urine. So you can code a 585.2, and you can make their diabetic code now a 250.40. It's very important to understand these kidney disease and the ranges and how you document this. But you can use a calculated GFR, but the easiest thing is to use your eGFR, which is on your lab sheet, and rely on this table to make those diagnoses. But the determination that chronic kidney disease is secondary to diabetes, again, is a clinical determination. You must have the connection, and you must document it explicitly in the progress note. If the patient's on renal dialysis or has an AV shunt, you want to use V45.11. If a patient is non-compliant, you want to use the V45.12 if they're not doing their dialysis. So which of these represent chronic kidney disease? Well, a GFR less than 60 for a year. Well, the definition of chronic kidney disease is GFR less than 60 for more than 3 months. So that would be a chronic kidney disease diagnosis 585.3 or 4, depending on the stage that they're at. The microalbuminuria and a GFR greater than 90. Normal kidney function, but microalbuminuria. Well, we just showed you that would be a 585.1. Now, you got to be very careful on these other ones. You have a patient that has a normal history of GFRs, but 2 months ago had a GFR that was 50. They repeated again, it was 65. So basically, they've had all normal ones and one abnormal one. You have to have that GFR less than 60 for 3 months to code that chronic kidney disease. You can't just change that chronic kidney disease diagnosis on one GFR. Here's some documentation examples. This is what the providers put in the chart. Patient has stage 3 chronic kidney disease, secondary type 2 diabetes, so it's perfectly legitimate, so code both of these codes, chronic kidney disease and the 250.40. Next example, the provider only put the patient has type 2 diabetes with diabetic nephropathy. Again, with. In this case, you can't code chronic kidney disease because there wasn't the documentation, so you have to use the nephritis code, which is 583.51. And probably the proper way to code this is the patient has type 2 diabetes with diabetic nephropathy and chronic kidney disease secondary to the diabetes, stage 2. Then you use all 3 of these codes. These 2 codes will cancel them out, but again, they do have some meaning in the entire risk assessment when you start looking at disease interactions, the model changing, so you want to make sure you include all the codes. Peripheral artery disease, if you document that it's a manifestation of diabetes, make sure you use the 250.7 category. If it's secondary diabetes with peripheral, you want to use the 249.7 categories. So PAD due to diabetes, if you document that in the chart and you have a good clinical reason to do that, then use the 250.70 and you use something like 443.81, the angiopathy peripheral, and the disease is classified elsewhere. Hypertension. This is one I think we all tend to undercode. In fact, when we look at charts in a lot of clinics, we find 90–95% of people use 401.1 or 401.9, benign hypertension, which is not risk adjusted. You get $0 for it, but that may be all your patient has. But what you need to pay attention to is the hypertension a cause of kidney disease or heart disease. So if you have hypertension without heart failure, but you have other heart disease that you can relate to the hypertension, like myocarditis or ruptured heart muscle, dilatation, something like that, then you can use the 402.10, which codes to the CHF, even though there isn't CHF in there. There's a CHF category, HCC category. The 402.11, the same thing. If you have documented CHF, ejection fraction, or however you want to document, code the specificity of that CHF, and you can use the 402.11. You have to have a cause and effect relationship, though, between the heart condition and the hypertension before you can assign these codes. If not, you got to go back to the 401s, and then you can use the 428s by itself. So this creates kind of an interesting scenario. A 45-year-old black male, long history of alcohol dependence and dilated cardiomyopathy. Most likely, you're going to use the code for this is 425.5 alcoholic cardiomyopathy. He then develops hypertension and diabetes years after. So how are you going to code this? Are you going to be using the 401.1 codes, or are you going to be using the 402 codes with the CHF? Are you going to be using both the CHF and the hypertension codes, or are you just going to be using the cardiomyopathy codes? Well, it all depends on what you document. If you document it in there, the EF is less than 25% and they have CHF, and then you can code alcoholic cardiomyopathy, diabetes without complications, and hypertension, which is not risk adjusted, and you get a score of 0.473. Now, if you documented the EF of less than 25%, you could actually, in that example above, now add the left CHF in there, the 528.1. You can also, if you can make a case for it, could say if the hypertension is due to, the CHF is due to the hypertension, then you can use the 402.11 code. However, again, remember, if you have cardiomyopathy first and hypertension, it's going to be a little tougher to make that call. I think the third example kind of highlights what we really need to look at here. The key thing is to remember is alcoholic cardiomyopathy, left-sided heart failure, and 402.11 hypertensive heart disease. All are going to code to HCC 80. All are going to get the same risk score. So as long as you have one of those codes, you're going to get credit for it. You're only going to get credit for one. It's the secondary codes that you use to change the risk score. Again, we're going to just assume that we're going to say that diabetes is not a result of the alcohol. It's just diabetes uncomplicated. If you wanted to say it was secondary diabetes, then you would use a 249 code here. But you're still going to get the same risk score of 0.127. However, in this case, when you've documented the heart failure, you now can use that 528 code .1, and you can get the disease interaction of 0.154. So now you've raised your risk score to 0.627. The hypertension and chronic kidney disease is the 403 group, and you can see there stage 1 through 4. So if you have patients that have hypertension and chronic kidney disease, and you can make a specific link to those two being a cause and effect. You want to change your 401 code to a 403 code, and just make sure you document it. Of course, if you have both end-stage renal, you have both heart failure and chronic kidney disease, then you want to use your 404 codes, and again, you want to use the codes with or without heart failure. So you want to use, if you do have the heart failure, you want to use a heart failure code. If you have and with chronic kidney disease, you must have the chronic kidney disease code in here too. So you're going to have all three of those diagnoses to use these codes. Cardiac disease, many of us use 414.01. Well, that gets $0, no risk adjustment. However, they do risk adjust old MI. One time a year, you've got to document the 412 code if they've had an old MI. An MI of less than 8 weeks, you use the 410 codes. Of course, if you had subacute or acute forms of ischemic disease, you use the 411 and the 413 codes for angina. Those all risk adjust. And in the future, if your patients fall into those 411 or 413 codes, you definitely want to use them over the 412 code, because there will be some changes with the 412 code risk adjusting in the future. But for now, you want to use it. Another thing we tend to do is use a pretty broad category, COPD 496, very general, non-specific. But a lot of times we'll also code acute bronchitis when in fact it may be a patient with COPD that may or may not have an exacerbation but has a chronic bronchitis. These codes risk adjust. Acute bronchitis does not. So anything acute, again, is really not going to risk adjust except for certain catastrophic events like sepsis and things like that. 492 for emphysema, 493 for asthma. All of these are going to risk adjust. A lot of chart reviews show that patients use providers use the wrong CPT code, ICD-9 code for patients that have had a CVA. CVA becomes history of when a member is discharged from the hospital after an acute episode. So at the point that we see them, if they don't have residual effects, we've got to use V.12.54. We don't code it 434.91 or 436. So if you have those codes on your patient's chart, you probably need to change them. Now, the ones that risk adjust are the V.12.54, but the residual effects of CVA are the ones that really risk adjust for us. Those are the ones where the person has residual effects from their stroke. So we're not going to use the 436 history of CVA. That's an acute but ill-defined cerebral vascular disease. Instead, what we want to use, if they have no residual effects, we want to use the V.12.54. If they have the late effects, that's the ones that risk adjust. We want to use the aphasia, slurred speech, gait problem, whatever. We want to use that 438 series or hemiplegia. Only use the 434.91 in a hospital setting, or for some reason a patient had a stroke in your office, but then you need to change it because after that stroke stabilizes, you have to change the code. So a patient presents to your office with dysphagia from a stroke a month ago. The dysphagia is still present. How are you going to code that? Well, the proper way to do that is the 438, the late effect code, and you use the dysphagia code, 787.20. If the office visit is to evaluate dysphagia from a stroke, but the dysphagia has now resolved, you're going to use no latent effects from the stroke. So you're going to use the V.12.54, stroke nonspecific. You must document the residual effect is caused by the stroke. It has to be in the chart. You must not say weakness for plegias, presence, or paresis due to CVA. That's not acceptable. Vascular diseases, phlebitis, which is the vessels are irritated from the clots or infection, 414.453. Blood vessels in the arms with reduced flow, that's your PVD, 443 codes. And then your atherosclerosis, your 440 codes, where you have the narrowing of the lumen and reduced elasticity. So if you have blood flow compromising the arms and legs, you're going to use your PVD code. You get a risk score of 0.318 with the 443 codes. Ulcers with gangrene or without gangrene, you're getting the foot ulcer score of 0.449. But one that we tend to miss is we see aortic atherosclerosis at 440.0. We find this on a CT or a chest X-ray. And if we feel it's clinically significant and we're going to be monitoring it, we need to document that, and 440.0 is risk adjusted. Cardiac arrhythmias, not just risk adjusted if you just use 427.9, but if you use the specific arrhythmia, AFib, A-flutter, PSVT, paroxysmal tachycardia, all of those, they all risk adjust. So you want to make sure you do that. Depression. A lot of people just use the 311 depression code, which is not otherwise specified. Does not risk adjust. That code's usually used just when it's secondary to bereavement or substance abuse or something like that. However, you want to make sure that your depressive patients don't fit the criteria for major recurrent depression, 296.1, 2, or 3, or any of these other mood or bipolar disorders. The reason is they risk adjust. Now, what do you need to document for major depression? Well, you need to go through this algorithm. Many of our EMRs may have this, but this is on the website, and you can incorporate it into your EMR. But basically, first you have to make sure you have all of the symptoms in the first box there, where you don't have substance abuse, it's not due to bereavement, and then you have to look and see if you have one or two of the next symptoms, where the depressed mood most of the day, or you have markedly diminished interest or pleasure. Then, depending on how many of those you have to make sure you either have 3 or 4 of the next 7. Again, that's a lot to remember, but most of us have EMRs now that we have other screening tools to use, or we can take this handout and we can create a template in our EMR for the documentation. So you need to look at those 311 diagnoses and make sure they don't qualify as a major depressive disorder. Malnutrition is one that's missed a lot, and it has a risk code of 0.8. It's a pretty high risk score. Unintentional weight loss, 10% over 6 months. Unintentional weight loss, 5% over 3 months. BMI less than 18.5. Albumin less than 3.5. Loss of appetite, poor nutrition, muscle wasting. All of these are characteristics of malnutrition. Each year, we need to look at some chronic conditions. HIV status, we have to document that. Is the patient insulin dependent, as we just talked about? Are they malnourished? Alcohol dependent, drug dependent? Again, the major depression versus the 311 code. Does the patient have a tracheostomy or is on a respirator? Things like that have to be coded each year. Even though they don't change, they have to be coded each year. Patients on long-term oxygen therapy, hypoxemia, or they use the V code for the O2 therapy. Again, we talked about the myocardial infarction, 412. Patients on dialysis, make sure you use that code. Patients that had organ transplant, those play into your role when you're diagnosing and treating a patient that's had an organ transplant, as does the artificial openings, the ostomies. And amputees, that's a huge one. Even though they may have had that amputation in 1985, you need to document it each year. So, how do we do with cancer? Well, cancer becomes a history of when all our current adjuvant treatment is completed. When that's the case, we use the V10 section of the ICD-9 codes, which don't risk adjust. Now, if it's ongoing surveillance following completed treatment, we use the V67, and I'll have to refer you out to that handout to look. There's just a handful of V67 codes that do risk adjust, mainly like bone marrow transplants and things like that. But let's look at this example, and this was an example I think came up the other night too. An 85-year-old white female with prostate cancer, white male diagnosed with prostate cancer 2 years ago, not treated with surgery or chemotherapy. Well, the patient refused treatment. So, do we code 185 malignant neoplasm of prostate, which is an acute diagnosis, or do we code personal history of because they decide not to treat? You code the 185 because it's a cancer that's active. Because it's not treated or not treated, it's an active cancer. Now, 60-year-old white male treated for colon cancer last year, stage 1. You document the 60-year-old with a history of colon cancer. So basically, you're saying the cancer is fully treated, there's no other therapy being done. So how are you going to code this? Personal history, or because it's only been a year, do you still code it as an active diagnosis, malignant neoplasm of colon? Well, the answer is you want to use the V10.05 personal history code. So, we have to pay attention to the needs and condition of the patient. We've got to add these ICD-9 codes that fit into these HCC categories on our chronic problem list and our acute assessment. We have to update our chronic problems so that the HCC are displayed on our diagnosis. We need to know all this. Evaluate these at least once a year. You want to look at these categories. And pay particular attention to your specialty consultations or reports so that you capture these diagnoses. So each year, what we usually do here is we do assessment of all our chronic conditions, CHF, diabetes, COPD, the coexisting ones we talked about, nutrition, the active status conditions, the amputations, the past medical conditions, MIs, things like that, and then look at the medication list to see if there's any conditions you may have missed. Specific rather than general, major depression rather than general depression. Causality, we want to make sure if the diabetic has a neuropathy secondary to diabetes, we document that. We want to make sure we submit all diagnoses on our claims too. Some of us get in the habit of just using a bare few that we feel we can justify with our EM codes. You want to make sure, because you only get a couple chances sometimes to get these codes in, that you put as many codes that have been assessed during that face-to-face visit. So remember, if it's in you have several diagnoses which fall into the same condition category, you're only going to get the highest one. So CAD and MI are in the same category, so you're going to be credited for the highest one, which is MI, but the risk score is still the same for both. You're just going to only get credit for one. And that's the same thing we say here, is that in diabetes, you have to make sure that you code both conditions which are the manifestation, but they're going to mainly, or a lot of times, fall into different HCC condition categories, so you're actually going to get credit for both of those. For certain conditions, there's an underlying etiology and a manifestation, as we've just talked about. Now, ICD-9 coding requires that you code the condition first, sequenced by the manifestation, and the diabetes is the main thing there. Just as we said before, make sure you use the renal manifestation 2504 before you use any of these other codes, chronic kidney disease, microalbumin, nephrosis, same thing with neurologic. Always use the 250 code and then your manifestation code. Here's some others for specified manifestations: foot ulcers, myelitis, skin abscess, gangrene. But make sure you use the diabetic code first. And as again, just in summary here on what we really need to remember not to overlook is that major depression. I keep re-emphasizing these because a lot of these things are important. A lot of times we just don't think about it. If they've had the old MI, the diabetes with complications, angina, they've had the history of cancer they have active cancer that you're diagnosing a history of because it's already been diagnosed, malnutrition, amputation status, dependency versus abuse on drug and alcohol. So, if you're coding acute bronchitis, you want to make sure, did you really mean chronic bronchitis in the patients that have COPD, or same thing with asthma? You know, a tremor that turns into Parkinson, are you still coding the tremor, or are you really coding Parkinson's? The tremor doesn't risk adjust, the Parkinson's do. So everything in the right column here risk adjust, the left column doesn't. Coronary artery disease doesn't, but the angina or old MI does. The CVA without weakness doesn't, but the late effects do. Impaired renal function does, chronic kidney disease doesn't. The dysarrhythmia of cardiac does not, but the atrial fib does. So what can we do at a practice level to maybe identify some of these patients? Well, you can run some reports. You can run reports easily on your patients that have GFRs less than 60. Make sure they have a diagnosis of chronic kidney disease. Patients with proteinuria, same thing. You can run reports on your patients that you've coded as 401.X with CHF for chronic kidney disease. You should be using the 402 or 403 if there is a link or it's documented. Same thing with the 404 if they have both of those. Some other easy screens to look for: your BMIs, they're less than 18, using that stroke code, and using the depression code. Again, you can't change the diagnosis except at a face-to-face if it meets the criteria, so you need to have that criteria. And diabetes, just some more examples of reports to run, the 250.0 code, and then you run for some of the manifestation codes that could be attributed to diabetes. And the old MI, the 414.1, you want to run that and make sure that patient, if they've had an old MI, you have 412 in there. So, as we said, check yearly. Make sure you have the documentation for these chronic codes in your progress note, and then make sure at least once a year you're coding for them. What we do at our practice, we have the quick coding tips in each exam room. We run these reports to periodically check to see if we do find patients that may actually not be as specifically coded as they should be. This is a perfect time of the year, flu season, For screening patients as they come in, we have our nurses look for those codes and bring it to the physician's attention if they see some things that potentially we just haven't documented correctly. We use monthly emails. We use benchmarkemail.com, which is about $30 for 5,000 emails, but we send it to, telling our Medicare to make sure you set up your wellness exam. That's a great time to update all these diagnoses. And then we directly notify the patients that haven't followed up in a certain amount of time or this year that we need to get them in. So you want to see each patient at least once a year. You want to evaluate and document all these chronic conditions. You have to make sure the data is captured. Office managers need to make sure they understand the limitations of your practice management system, how many diagnoses your system allows, and there's potential for codes to be dropped. Make sure if you're using superbills that you update those codes to the more specific ones or your favorites list in your EMR, and always code all diagnoses, as many as you can, capture them, and make sure they're properly documented. Code it to the highest level of specificity. Now, another key thing is you got to make sure that the diagnosis codes are extracted and sent to CMS. You have to make sure your claim the limits on your claims and make sure they can be submitted with more than 4 diagnoses in some cases, or make sure they are receiving all 4. But practices that are in habit of only sending 1 or 2 to support the E&M, they should be submitting 4 on these Medicare patients just about every time. And office managers need to verify that your clearinghouse or your submission vendor can send and receive all these recorded codes. It doesn't do you any good to send them if they can't send them on. So let's look at a couple quick examples here. 85-year-old white female, diabetes type 2, symptoms of a UTI, malnourished, she's lost 30 pounds, leukoesterase in the urine, microalbuminuria, complaining of urinary discomfort, dry skin, some past medical history there, diabetes, chronic kidney disease, BKA, MI, creatinine 1.3, you have lab findings revealed CKD of stage 3. You write your plan up, Amaryl, Cipro for the UTI, Amaryl for the diabetes, insure supplements, return to clinic 3 months, refer to nephrologist. Well, to many of us, we code this right away with just diabetes, uncomplicated, UTI 599, maybe throw in the cardiovascular disease. We're going to get a risk score of 0.127 because UTI and 414 are not risk adjusted. We're going to always get the demographic. So this, if this is the only diagnosis codes going for this lady for that year, we're going to get about $4,800 in expenditure, a risk code of 0.567. But let's look and see what happens if we actually use the right codes. Diabetes with renal, we get 0.3711. We still don't get anything for diabetes acute code, but we do get for the diabetic nephropathy, the chronic kidney stage, 0.368. The diabetic nephropathy will be trumped by that chronic kidney stage 3, so you'll only get one of those. The old MI, 412, the BKA, the malnutrition, and then we get the demographic. So now, when we're $4,800 for just the diabetes and the UTI code, we now get $22,000 allocated to the same patients based on the problems that we're following for and treating her for. A difference of $17,000. You do this on several patients, you can see right away where you could have problems showing risk shared savings based on a risk population if it's not properly coded. Again, this one will ignore the demographics, but kind of look at just the problem list: COPD with asthma-like flare, diabetes uncontrolled, colon cancers, mets of the liver, anemia, peripheral neuropathy, old MI, worsening asthma, foot ulcer with peripheral vascular disease, depression, and a GFR 75 with microalbumin. Well, if we do the low-level coding, diabetes uncontrolled, we only get 0.162. The neuropathy, if we don't do the specific one, we get 0. Foot ulcers, we get some credit for. Peripheral vascular disease, we get some credit for. Don't get any credit for the 414 for the MI. Don't get any credit for the asthma, 493.91. Don't get any credit for anemia. We do get some credit for colon cancer. Don't get any credit for depression, as it's nonspecific, or the renal insufficiency. But so basically, we got a risk score of 1.135, $8,200 for the year. But during the year, we coded all of these stages. We're going to see that risk score dramatically change. You'll notice we've got diabetes with renal complications, and then the manifestation is right after. We're getting credit for both of that. Because renal trumps all of these, we still code the diabetic neuro, but we get credit for the diabetic neuropathy. We code the diabetes with other uncontrolled, but it's, again, trumped by the renal, but we get credit for the foot ulcers. We get credit for peripheral vascular disease. We now get credit for the old MI. Colon cancer stays the same, but we added the Mets, and we got 2.276 because we had metastatic disease. Coding the asthma with COPD rather than asthma gets risk adjusted. The patient did qualify to have major depression. It wasn't situational depression. Anemia just doesn't get risk adjusted except for like aplastic anemia. But now, $38,000 because our risk score is up to 5.3. So a couple of these patients you can see on a yearly basis and miss, and you can see where your expenditures are going to be well understated. Just briefly, again, close one eye, one ear on this because you want to code exactly like I just said for 2013 because those codes will go in and be risk assessed for this year. But 2014, there's going to be some changes. The chronic kidney disease, you'll no longer get credit for the 1 through 3 stages of the nephritis. You will for 4 and 5. However, you're going to need that chronic kidney disease to get your 250.40 or your hypertensive heart disease, kidney disease codes. So you need them still. Make sure you use it. Peripheral neuropathy, the 337.1 will not code risk adjust, but the 357 category will. So if it's a polyneuropathy and diabetes, you want to make sure you're using 357.2 rather than 337.1. They are going to remove the old MI, asphyxia, and hypoxia, but you still want to make sure it's there this year. They're hoping that, or the thought is that this will all be captured because people will code a little more specific for ischemic heart disease and angina and other ongoing problems. So if your patients have an old MI and they have any kind of issues with ischemia or angina, you make sure you change or add those codes, but make sure you document it. Skin ulcers will not be coded. Stage 1 and 2, only stage 3 and 5 will be risk adjusted. Pancreatic disease, again, acute pancreatitis will not be risk adjusted. Chronic pancreatitis will. Celiac disease has been eliminated because most of the time it's treated with diet. Now, again, I've just put up some examples here, but there are some new categories. Sepsis is a big one. Morbid obesity, if you start seeing that, greater than 40 BMI, start coding that. That will get risk adjusted next year. There's a whole slew of new endocrinological ones that get risk adjusted. This is just a sample of that. Same thing with coagulation defects. There's 48 ICD-9 codes in this HCC category. Again, this is just some samples of those. Lung disease, they've expanded. New category 112, added some of the chronic lung diseases, asbestosis, farmer's lungs, things like that. They're also changing our disease interaction codes. There's going to be 2 new ones, sepsis and respiratory failure, and cancer and immune disorders. They're going to kind of consolidate the diabetes from four of those into 2 of those. So as I showed you in that first slide, the red ones, the diabetes, CVD, and renal failure, CHF diabetes will be eliminated, as will the COPD and the CVD and the coronary artery disease. However, for this year, you still need to make sure you code all of that. So how is this going to look on paper? How's this going to work? Well, in 2013, your diabetes without complications still is in category 19. In 2014, it's still category 19. However, your diabetes with neurologic or any kind of manifestations are now going to all be grouped into 18. Major depression is going to be grouped into HCC 58. As I said, peripheral neuropathy, which is part of 71 right now, will not risk adjust in 2014. So if you have polyneuropathy secondary diabetes, you want to use the 357.2. Diabetic retinopathy does not, will actually join the diabetes 18 HCC category, but proliferative retinopathy will still risk adjust. PVD unspecified will move from 105 to 108. What does this mean for risk scores? Well, the simple answer is 25% of what was calculated in 2013, giving us credit for all the things that may be removed, will be added to our 2014 score. So if you look here, you'll see in 2013 you're going to get credit for diabetes with neuro, and you're going to do the same in 2014. Depression, you'll get credit. The categories will move, and the risk weight will change just a little bit, but you will not get any credit for polyneuropathy in 2014. You still will have the peripheral vascular disease. So in 2013, your risk score is 1.301 after being normalized. In 2014, it's going to be 0.9 because you're not going to be including that polyneuropathy. So the way they're going to calculate this, they're going to take 25% of that score from 2013 and add it to 75% of the 2014 score. So your risk score is going to be about 1.054, where it would have been 1.301. So in summary, remember, always follow the guidelines for the coding book, the ICD-9 coding book. Always have appropriate documentation. If you need to refer to any of these reference materials, have them all out there at www.keymh.com. If you have any questions, you can contact me or send me an email. So I appreciate you all attending tonight, and if you have any further questions, please don't hesitate to